Okay, I'm sorry. Yeah. Hello, good afternoon, ladies and gentlemen. It's my pleasure to be present at Egypt EDDW. Here I will share a case to show how to use endoscopy to share to make the diagnosis and differentiation and of intestinal ulcers. The topic of my presentation is identify disease by bright eyes and endoscopy. Let's start with the patient's information. The patient was 21 years old, male student. The chief complaint is intermittent diarrhea for 2 months. Admitted to hospital on 2019 February 25. The kind of history was 2 months before admission, reported diarrhea with 3 to 5 bowel movements per day, with no stool and a few mucus without blood, occasionally bloating, and had no abdominal pain, no fever, no cough, no sputum, or light sweat. He had weight loss, no perianal lesion or fistula. The patient was no special disease history. He was healthy before. No contact or past history of tuberculosis. No past oral ulcer history. No smoking and alcohol. No allergy for any medication and any food. No special family history. And the physical examination showed BMI was 17.92. No other abnormal sign. And here is a laboratory test. Laboratory test showed fecal analysis for bacterial function, bacterial culture, parasites, sedative toxin, and acid fast stain were negative. The blood test showed WBC and BPC were normal. The RBC and HGB decreased, suggested anemia. Liver and kidney function were normal. Total protein and ARB decreased, suggests malnutrition. The potassium and the sodium were also decreased. The inflammatory biomarker CRP and the ESR were remarkably increased. Some serum biomarkers for IBD, including ESEHG, anti-intestinal goblet cell antibody, and ANCA were negative, were normal. Tuberculin skin test, PBD was positive. The interferon gamma release assay for Mycobacterium tuberculosis, IgRA, was positive. And here is the radiology examination. And the CT scan of the abdomen and the pelvis were normal. And here is CT of chest. And the CT scan of lung showed a variety of lesions. There's some delay. There's some delay of the, yeah, okay. A CT scan of lung showed a variety of lesions, such as patching and nodule and bands of uneven density enhancement, suggesting exudative proliferative lesions, which was suspicious of TB of left lung. And here's an MRI of intrography. Contrast enhanced image showed bowel wall thinning and homogenesis, you can see here, and homogenesis enhancement without stratification of the interstitial region. Here, image show here. The image, the PPT is delay, transmission delay. And then we performed the full inner colonoscopy procedure, and we found irregular or round-shaped rodent, deep and large ulcers covered by white fur. Ulcer board was unclear and merged each other. Diffuse distribution in terminal ileum and colon was in ileocecal junction, ascending and transverse colon. Ileocecal valve is petulous. Open neck fish mouth. You can see here is the terminal ileum iliac junction, ascending colon, ascending colon. Here is transverse colon, transverse colon. The mucosa of descending colon and the sigmoid colon and the rectum were normal. And we took the biopsy at multiple sites. The pathological reports showed ascending colon showed severe active inflammation with ulceration. Granuloma is present. Acid fast stain negative. Transverse colon tissue showed moderate active inflammation with ulceration. Granuloma is present. Terminal ileum tissue showed severe active chronic enteritis with esophageal. So the pathological diagnosis was tended to take into account intestinal TB. However, it's necessary to rule out CD firstly. And so what's the cause for the ulcers? 1, intestinal TB, 2, Crohn's disease, 3, primary intestinal lymphoma, 4, intestinal basis disease. As we know, the endoscopy plays a key role in diagnosis, discrimination, evaluation of therapy, and surveillance of intestinal disease, particularly ulcers. So some typical appearance and endoscopy can give us the clue and to help us to make the right diagnosis. So let's say the typical features and the colonoscopy of this disease. For intestinal TB, the more common features and the colonoscopy was round or ring or oval-shaped irregular geographic ulcers. And the ulcers often merge. Rodent bite-like margin and stenosis. The ulcer can involve any part of GIT, multiple segment in intestine. The site is predominantly the iliac region and the small bowel. Iliac valve, the appearance of iliac valve is very specific. It's patulous, scar or pseudopolypus, lack of epithelial ulcer or cobblestone appearance. Here's the more common features of ITB. For Crohn's disease, here's a more common feature and the colonoscopy of CD were longitudinal ulcers or epithelial ulcers, non-continued multi-segmental scape lesion, and the cobblestone appearance, clustery polypus proliferation. And then bowel wall often shows thickening or lumen stenosis or stricture. Here are the more common features of CD. And for primary intestinal lymphoma, more common features and the endoscopy of PIL include multiple deep and large ulcers with various shapes, multifocal ulcers, or diffused or irregular ulcers covered by foul moss. Burden of ulcer with remarkable proliferation response, dam-like elevation mucosa, just right here. And looks like crater. The ulcer can involve in whole GI tract. And then the intestinal basis disease, BD. More common features and the colonoscopy of BD includes the amount of ulcer usually less than 5. Focal distribution, most located as a iliac junction. Ulcer is isolated and deep with round or oval or geographic shaped with distinct margin. You can see here, here is a lesion, the ulcer. The margin is very clean. Mucosa surrounded ulcer usually no obvious proliferation reaction. And the ulcer without epithelial or cobblestone-like appearance. So here are the more common features and the colonoscopy of BD. And since TB is high prevalent in China, and the differentiation between ITB and CD has been always changing for us. Here's a compare of clinic, endoscopic, histological, and serologic parameters for discriminate ITP and CD. And for duration of symptoms, for ITP is shorter and the CD is longer. The duration of disease is longer. And the clinical presentation for ITP usually has a fever, associated pulmonary involvement, and ascites. But for CD, the presentation, including chronic diarrhea, hematochezia, perianal disease, and actual intestinal involvement. And for endoscopic findings for ITP includes transverse ulcer, pendulous ileocecal valve. And for CD, the endoscopic findings usually showed aphthous ulcers, longitudinal ulcers, cobblestone appearance, pseudopolypus, and scape lesions. And for histology findings for ITP, ITP usually showed multiple large confused granuloma, cascading granuloma underlined by histiocytes. And for CD, the histology findings include microgranuloma and focally enhanced colitis. And the response to ATT therapy for ITP, the response usually very good, early mucosal response, after healing at 2 months of the therapy. And for CD, less likely to have response and to show mucosal response with ATT therapy. So here's a compare between ITP and CD. And so for these patients, the evidence for support was transverse ulcer, patulous ileocecal valve, PPD, and HLA are positive, and actual intestinal TB, non-TB exists. In contrast, the Crohn's also has also included no systemic TB manifestation, such as fever, neck sweat, acid fast, bacilli AFB stain in tissue negative, no executive cases, necrosis in histology section. So based on above information, we tend to make the primary diagnosis as intestinal TB, ITB. And then we made the standard diagnostic anti-TB treatment strategy, ATT strategy. Well, the patient took NH, RFP, PZA, and EMB 4 medication combination for treatment. And fortunately, the patients showed a very good response for the treatment. And the 4 medication complication lasted for 2 months, and followed by NH and RP, the 2 medication complication for 8 more months. And here's the follow-up. And 3 months after ATT, repeat ileal and colonoscopy showed the major remarkable improvement. And we can see the scar and the pseudopolypus formation, and the mucosal gets smooth. And the repeated CT scan showed that the lesion obviously improved in the left lung. You can see here the lesion get improvement. And the compare of CT for chest, I put the image together, and so it's easy to compare. You can see before the ATT treatment, you can see here the lesion here, right lesion here, and after ATT the lesion got remarkable improvement. And MRI of the angiography and the repeat contrast enhanced image showed that the lesion marked the improvement. You can see here, and in the sacral region, and also I put the image together so we can compare the difference before and after ATT treatment right here. And before ATT treatment, we can say the bowel thickening and the enhancement and homogeneous enhancement. And after ATT, the lesion got remarkable improvement. And we continue to follow up, and 10 months after ATT, we repeat again to do the inner colonoscopy, and the colonoscopy showed the mucosal get smooth, and the scar and the pseudo polypus formation. And so the mucosal was healing. And so the final diagnosis of this patient is intestinal TB. And here is our IBD center and IBD MT group. Our IBD center and IBD group are influential in China. And the IBD MT group is comprised of Department of GI and Rectal Surgery, Histology Center, Imaging Center, Department of Pediatric, and Department of Psychiatry, and the Department of Nutrition. We routine to get together to discuss and hold the workshop. And we take care of our IBD patient as chronic disease management. And here is a logo of our IBD patient group. We also developed the IBD patients education program and benefit the patients. So lastly, take-home message. Endoscopy plays a crucial role in the diagnosis, discrimination, evaluation of therapy, and the surveillance of intestinal disease. Increasing use of endoscopy unravels ulcers in a relevant number of patients. Although often attributed to IBD, these ulcers may be unspecific or caused by a variety of other diseases. A typical morphology and characteristic of ulcers and endoscopy can give us the clue and help us to make the right diagnosis and differentiation on intestinal ulcers. Due to a massive overlap in the endoscopic appearance of intestinal ulcers between possible causes, diagnosis should be based on broad information, including history, histology, imaging, and laboratory tests. Thank you for your attention.
Thank you, Professor May, for this nice case presentation. The most important of differential diagnosis, if we find intestinal ulcers between chronic disease and tuberculosis. And you mentioned also the most two important differences in the ulcers. Usually TB are transverse ulcers with the fold of the mucosa. And we have large granulomas and maybe caseation. And you presented a typical case of tuberculosis, and the patient showed very good response to treatment. What about the laboratory response of treatment? The CRP, the anemia, all improved or not?
All improved, yes, of course, yeah. All improved. And after 2 months after ATT therapy, the CRP and the ESR are all restored normal.
Yes, and the lung lesion also responded to treatment, and this is improved that you have the right diagnosis of TB, intestinal tuberculosis. If there is any question from the audience, okay. My colleague, Professor Dr. Ali, will present our next case. Thank you, Professor May.
Thank you very much. It's my pleasure.
I have the pleasure to present the second speaker in these two cases discussion, Professor Zhao Bing Wang, and she will present the case with the title, When Liver Cirrhosis Encounters Internal Hemorrhoids Bleeding. Okay, Professor Wang, go ahead.
Good afternoon, everyone. I'm very glad to have the opportunity to communicate with colleagues from Egypt. The topic of my report today is when liver cirrhosis encounters internal hemorrhoids bleeding. First, let's review the medical history of the case. The patient is the 68-year female with the chief complaint, intermittent hematemesis and hematochezia for more than 2 years. On January 3rd, 2018, the patient vomited blood with shock. She was diagnosed as hemorrhage from esophageal varices due to hepatic cirrhosis in another tertiary hospital and received endoscopic sclerotherapy for 4 times by June 2019. On March 21, 2020, the patient had red blood stools for many times with dizziness and fatigue. She was admitted into the same hospital and considered as the internal hemorrhoids bleeding, and then received conservative treatment. In the following 3 months, she was admitted into the same hospital for bloody stool and received endoscopic sclerotherapy twice and was discharged on July 10th. On July 30, she had bloody stools again and was admitted into our hospital. The patient had a history of hypertension, diabetes, and hypothyroidism, a history of non-alcoholic steatohepatitis, a history of multiple blood transfusions, and with no other special medical history. Physical examination indicates anemic appearance with no other positive signs. Inspections of another hospital was shown in the next slide. Unfortunately, we only have photoscopies from patients. On June 17th, the patient received a gastroscopy, which indicate moderate esophageal varices, chronic gastritis, and gastric polyps. There was only low risk for esophageal varices bleeding. On June 19th, the patient received her first colonoscopy, and the rectal varices were found less than 10 centimeters from anus. Hemorrhoids node with thrombus was obvious, which communicated with rectal varices. Endoscopic sclerotherapy was performed using 10 millimeter lauromacrogel, injecting into 3 points. On July 1st, a second endoscopic sclerotherapy was carried out. During colonoscopy, hemorrhoids node with congestion was also obvious. Injection into 6 points were performed using 8 millimeter lauromacrogel. The patient's conditions, the following initial diagnoses were made, including decompensated cirrhosis with hemorrhoids, variceal bleeding, esophageal varices, splenomegaly, and hypersplenism, severe anemia, ascites, hypertension, type 2 diabetes, hypothyroidism. The most important question is how to treat bleeding. After admission, the patient received some routine examinations. Blood RT indicated decreases of white blood counts, red blood cell counts, platelet counts, and hemoglobin. The stool RT and urine RT were normal. Liver and renal function indicated decreases of total protein and albumin, and a slight increase of GGT. Blood coagulation test indicated slight abnormalities for prothrombin time, prothrombin activity, and fibrinogen. A slight increase for D-dimer was also found. Hepatitis B core antibody was positive. The other indicators were all normal. From the CT angiography for portal vein on August 1st, we could see ascites, splenomegaly, thrombus in left branch of portal vein and in main portal vein. Echocardiography on August 2nd reviewed abnormalities of left ventricular dilation, mitral regurgitation, tricuspid regurgitation, aortic regurgitation, and arrhythmia. Which way should we select to treat? Before giving suggestions, let's review the anatomy of the anorectal veins. From the sketches, we can see a venous network of rectum and anal canal. The direction of venous return above dentate line was as follows: from superior rectal venous plexus to superior or inferior mesenteric vein and to portal vein. The directions of venous return below the dentate line was as follows: from inferior rectal venous plexus to internal iliac vein and to inferior vena cava, which are associated with internal and external hemorrhoids, respectively. The main trend for internal hemorrhoids were rubber band ligation and sclerotherapy. Rubber band ligation was used to treat patients with hemorrhoids from grade 1 to 3, especially for patients with prolapse. The common complications were pain and bleeding. Sclerotherapy was used to treat grade 1 to 3 internal hemorrhoids. Sclerosing agents are injected into the bottom of the hemorrhoids, causing inflammation and eventually fibrosis. The most widely used agents were laromestrogel and palidocanol. The patient received endoscopic sclerotherapy twice on June 19th and July 1st. There was a great possibility of failure for a third sclerotherapy. The patient and her family refused to take a third sclerotherapy again. Is endoscopic band ligation appropriate for her? A prospective randomized comparative study was to compare endoscopic injection sclerotherapy to endoscopic rubber band ligation regarding the effectiveness and complications in the treatment of bleeding internal hemorrhoids in Egyptian patients with liver cirrhosis. Both EBL and EIS were effective in the treatment of bleeding internal hemorrhoids in patients with liver cirrhosis. EBL has significantly less pain and higher patient satisfaction than EIS. EBL was also safer in patients with advanced cirrhosis. However, there was a different viewpoint about bleeding internal hemorrhoids in patients with cirrhosis. Of note, rubber band ligation is generally contraindicated in patients with advanced cirrhosis due to the risk of profound secondary bleeding following the procedure. Injection sclerotherapy is an effective and safe procedure for treating bleeding hemorrhoids in this situation. In addition, consensus of Chinese expert on hemorrhoids ligation 2015 gives some contraindications of rubber band ligation for hemorrhoids, including severe heart, liver, and kidney diseases and coagulation dysfunction, including anticoagulation therapy in process, a history of pelvic radiotherapy, severe immune deficiency, serious infection or inflammatory lesions in rectum and anal canal, a history of sclerotherapy within 3 months. This patient suffered from decompensated cirrhosis with abnormal coagulation state and had ever received sclerotherapy within 3 months. Thus, the EBL was not suggested. Since EBL and the EIS were both inappropriate, As surgery was also potential treatment for hemorrhoids, we invited the surgeons to take part in group consultations based on the fact of decompensated cirrhosis with ascites, coagulation dysfunction, and portal vein thrombosis. They thought surgery was very risky and not the best choice, considering the possible relationship between bleeding and portal hypertension and the definite efficacy of TIPS on portal hypertension. TIPS might be another way to work for her. What is TIPS? Transjugular intrahepatic portal systematic shunt is a shunt placed between the portal vein, which carries blood from the intestines and intra-abdominal organs to the liver, and the hepatic vein, which carries blood from the liver back to the vena cava and the heart. It is usually primarily, but not exclusively, in patients with cirrhosis in which the scar tissue within the liver causes partial blockage of flow of blood passing through the liver from the portal vein to the hepatic vein, which leads to portal hypertension. A successful TIPS can effectively relieve portal hypertension. Before TIPS placement, in order to get direct evidence that there was possible association between hemorrhoids, bleeding, and portal hypertension in this patient, we suggest her to receive a contrast-enhanced CT for lower abdomen and pelvis on August 4th. In the picture, the red circle and white arrow indicated an abnormal varicose vein in the anorectal wall. And in video, tracking from distal to proximal, up, and up, and okay. In the last static diagram, we saw an expected point, which referred to the confluence of superior mesenteric vein and the splenic vein. Based on this finding, TIPS might be effective treatment for bleeding hemorrhoids in this patient. We also performed a colonoscopy on August 7th to understand the conditions of the hemorrhoids bleeding and the varicose vein. From the colonoscopy, we saw mild rectal varices and hemorrhoids and obvious internal hemorrhoids. Bleeding points at 3 o'clock and 11 o'clock were found by inverted observation. We have understand the anatomy of anorectal vein, and now we can answer the questions about whether there's association between bleeding hemorrhoids and portal hypertension in this patient. What are the benefits of TIPS for this patient? First, a successful TIPS can decline portal pressure to reduce the rebleeding of esophageal varices and relieve ascites and hypersplenism. Second, TIPS placement can increase the blood flow velocity of portal vein, which would be helpful for the clearance of thrombus and the recanalization of portal vein. Third, during TIPS, we can perform direct embolization of varicose vein to treat bleeding. Now, let's go into the TIPS creation. After a successful puncture into portal vein, we performed a transcatheter splenic venography indicating no manifestations of esophageal and gastric varices. And then we performed a transcatheter superior mesenteric venography. and found retrograde flow in a vein, this vein. Moving the C-arm of DSE machine to the distal, we performed another transcatheter superior mesenteric venography and found flow into distal with suspicious vascular network in the end, this area. The catheter was super selectively put into the abnormal vein, and a clearer variceal network was shown, this area. Then an embolization of varicose vessel with coils was performed. After embolization, no flow to distal was shown. After Valter stent was successfully placed, transcatheter splenic venography indicated an unobstructed flow back to the heart. And the daring tips, some thrombose in main portal vein was removed by aspiration. After these successful tips, there were some questions worthy thinking about. The first, does cirrhosis increase the risk of hemorrhoids and bleeding? The prevalence of hemorrhoids in patients with liver cirrhosis ranged from 21% to 79%, and there was no significant difference between groups with and without cirrhosis. Hemorrhoids account for about 37%, were the main cause of cirrhosis with lower gastrointestinal bleeding, followed by colorectal varices and portal hypertensive enteropathy, about 23%. The progression of hemorrhoids was independent of severity of cirrhosis, the degree of portal hypertension, and EBL therapy. In patients with cirrhosis, the prevalence of symptomatic hemorrhoids, including bleeding, is about 5%, which is similar to that of the general population. However, due to abundant collateral circulation and possible severe coagulation dysfunction, the treatment of cirrhosis with hemorrhoids is often very difficult. Point 2, are there any standardized treatment for patients with cirrhosis and bleeding hemorrhoids? At present, there's no standard treatment for cirrhosis with hemorrhoids bleeding. Limited experience and literature are most from the treatment of rectal variceal bleeding. In clinical practice, many methods, including drugs, endoscopy, surgery, angiographic intervention, and tips, are all used as the treatment of cirrhosis with the internal hemorrhoids bleeding. However, because the absolute number of bleeding in patients with cirrhosis and hemorrhoids is low, and the incidence is also low, usually less than 5%. There's a little high-quality RCT or study comparing the efficacy of different treatment modalities. In the case of specific cases, the choice of treatment is mainly based on the experience of doctors and the comprehensive treatment level of the hospital. Point 3, does this patient need anticoagulation therapy after TIPS? RCT gives some suggestions. They concluded that an anticoagulation therapy may not be necessary in certain patients with PVT because TIPS placement alone can achieve a high persistent recanalization rate. At last, the summary. There's no standard treatment for cirrhosis complicated with hemorrhoids. Endoscopic sclerotherapy can be used as the initial treatment. Because of the potential risk of secondary hemorrhage, the ligation is not recommended for such patients. If endoscopic treatment doesn't work, TIPS can be used as an alternative treatment after excluding other causes. However, until now, there is still no high-quality data on its efficacy and safety. Welcome to Zhongnan Hospital of Wuhan University. Thanks. That's all.